Hi, my name's Rhiannon. This is my capstone project on how music affects the mood and depression screenings of our dementia patients. Dementia is defined as an acquired deterioration and a progressive failure of many cerebral functions that include impairment of intellectual processes with a decrease in orientation, memory, language, judgment, and decision making. While the prevalence of most diseases decrease each year with a rise in effective treatment options and improved care for those diseases, the annual deaths from dementia is rising at a rate of about 150%. This disease is caused, at least partially, by neurolytic plaques and neurofibrillary tangles in the cerebral cortex, as well as amyloid deposits in the smooth muscle of cerebral arteries. But we are still lacking a full understanding of the disease. The most popular medications used to treat the symptoms of this disease include antidepressants and psychotropic drugs. However, there is little evidence showing that the positive effects of these medications outweigh the potential adverse effects, especially in our geriatric population. Specifically, intensive evidence has demonstrated marginal clinical benefit of using antipsychotics in dementia management and serious adverse effects, including stroke, myocardial infarction, and death. In addition, the cost of dementia treatment and management is astronomical, and largely due to pharmacological treatment. The annual cost per person that was attributable to dementia in 2010 was between $40,000 and $60,000 per person. This statistic suggests that the monetary cost of dementia in 2010 was between $157 billion to $215 billion. This has actually recently increased into the trillions. Complementary medicine is usually inexpensive and in some cases may be used as a substitute for medications, which will, of course, lower the cost of the care for this disease. In this DNP project, the effect of music listening on mood of dementia patients was studied. The literature was reviewed for studies completed on music listening and interventions, and its effects on mood and quality of life of dementia patients. In summary, this project has explored whether a combination of music listening and pharmacological treatments will improve the moods of dementia patients in long-term care facilities as compared to using only pharmacological interventions for treatment. So that was a lot of information, but more or less the purpose of this study is to discover if music listening and music discussion will improve the mood of dementia patients as compared to using only standard care. Okay, a quantity evaluation via retrospective chart review was the intended methodology for this project. There was no direct engagement of human subjects. Data was obtained through the record review process only. Rushville Nursing and Rehabilitation Center added two weekly 30-minute music listening and discussion sessions to their daily activities. A chart review of resident PHQ-9 scores prior to the initiation of the music listening and discussion program and 1 month after the initiation of the program was conducted. At this point, paired t-tests were used to analyze the data. Inclusion and exclusion criteria in the study were fairly simple and self-explanatory. Inclusion criteria included anyone at least 18 years of age and being a current resident of Rushville Nursing Home and Rehabilitation Center. Of course, these were easy to fulfill as most residents with dementia are older than 18, and I was only looking at residents at this facility. They also, of course, had to have a documented diagnosis of dementia on record. Exclusion criteria included residents who had acute confusion or delirium, but not dementia. So this is important because, of course, in a long-term care setting, we take care of patients with dementia, but we also see a lot of acute confusion and delirium. But I did make sure not to include these patients because that is, of course, very different than a terminal dementia diagnosis. I also excluded residents with a diagnosis of infectious disease, such as COVID, because this would keep them from participating in the music program. As you would expect, any of our residents that had COVID at the time were unfortunately forced to stay in their room during the music listening sessions. So they, of course, did not have any benefits of that. So I did have to exclude those few residents. The PHQ-9 screening tool was used for a few reasons. This is a very common tool used often in primary care to evaluate depression in all adults, but of course, our elderly adults as well. And this PHQ-10 assessment screening tool was actually already being used at Rushville Nursing Home to screen for depression of all residents. So it was already in their charts. So it was easy to access and gain that data. Okay, so I touched on inclusion criteria and exclusion criteria. As far as the analysis plan, a paired sample t-test was used to analyze the data collected in this project. In the study, the data was collected from the same sample 1 month apart. The t-score showed the ratio between the group scores at the beginning of the 1 month and then at the end of that month. SPSS software was used to complete the data analysis of this project. This is a data software package that is used to calculate a plethora of types of statistical analyses. While SPSS software can be costly, this cost has been factored into the budget of this project. This really was a fairly easy study to complete. I really didn't have to use too many resources to do so. The few resources that I did need involved looking at and analyzing the data. I did need a few people to assist in the project, which included the facilities DON, my researchers, my project chair, and several additional Maryville staff helped me along the way. The research was conducted at Rushville Nursing Home and Rehabilitation Center. I was able to access this facility free of charge. Materials were simply pens, paper, folders, a locked filing cabinet, which I did already have, a laptop calculator, SPSS statistics software, printer paper, and ink. Although this study did have a very small budget compared to more extensive research, I did need a few funds. The total budget of this study came out to be about $185. As any project, the protection of human subjects was considered while I was completing this study. No obtained consent was needed for this study as it was only a retrospective chart review. No additional sample risks were noted as the study was only, as I said, a retrospective chart review, and therefore no human contact was included. A breach in confidentiality, while unlikely, was the only possible risk of the subjects involved in this study, and several steps were taken to protect from a breach in confidentiality. The hypothesis presented in this project is that adding 30-minute music listening and music discussion sessions 2 days weekly to current practices at a long-term care facility will show decreased depressive symptoms in dementia patients. To test this hypothesis, a chart review was performed and comparing residents' control PHQ-9 scores to residents' PHQ-9 scores after a music listening and discussion activity group had been implemented at the long-term care facility where residents resided for 1 month. It can be summarized that the results found from this study were statistically insignificant, and therefore this hypothesis presented was not supported by findings of the study. While post-PHQ-9 scores were slightly decreased from the pre-PHQ-9 scores, the correlation coefficient was small. The range of possible PHQ-9 scores are 0 to 27. Scores of 5 to 9 are classified as mild depression. Scores of 10 to 14 are classified as moderate. Scores of 20 and above indicate severe depression. 38 research subjects in the long-term care facility with a diagnosis of dementia were screened prior to music listening and discussion, and 1 month into music listening and discussion. The mean pre-intervention PHQ-9 score among the research subjects was 6.6316, while the mean post-intervention PHQ-9 score among the research subject was 5.9474. According to these results, depression was decreased by an average of 0.6842 points on the PHQ-9 scale from pre-intervention to post-intervention. The standard deviation of the pre-intervention data was 5.46, and the standard deviation of the post-intervention data was 4.74. The mode, median, and range of the pre-intervention data was 0, 5, and 18 respectively. The mode of the post-intervention data are 7 and 0, while the median and range of the post-intervention data are 6 and 16 respectively. While these descriptive statistics do show a decrease in the depression from pre to post-intervention according to the PHQ-9, the correlation coefficient was 0.905, and therefore this decrease is non-significant. Lastly, from the paired differences t-test, it was deducted that the average pre-intervention scores were 0.84 points higher than the post-intervention scores, with a p-value of 0.079. This is just a line graph of the data that was founded. You can see here that the purple line represents the post-PHQ-9 scores, while the green line represents the pre-PHQ-9 scores. So you can see that really there wasn't a huge difference between the post and the pre-PHQ-9 scores. However, over here it does look like the post-PHQ-9 scores were slightly lower than the pre-PHQ-9 scores. You do notice that over here at the beginning there are a few outliers of post-PHQ-9 scores being high. This was for a few different reasons. We did have one resident that lost his wife during this time, so I definitely think that this was a huge component of why his score was drastically increased. I don't believe by any means that the music listening program caused an increase in depression in these two residents. They had a few other extenuating circumstances that I believe did cause the increase. This graph here shows the same information, it's just presented a little differently in a bar graph. Collectively, the findings from both this study and the 9 other studies reviewed in this project suggest that music does have a slight to significant effect on mood of patients with dementia. No studies found music interventions to have a negative effect on mood. Some anecdotal evidence was found while completing this project, which may be worth noting. While this study was not designed to have a qualitative component, the majority of the participants showed signs that they thoroughly enjoyed these sessions. The researcher personally saw residents transform from indifferent to fully engaged when they began to hear familiar tunes. Their eyes would open widely, they would smile, and even their posture would improve. Additionally, all of the studies reviewed had qualitative components showed positive findings. For example, one study stated that the music showed brighter moods and increased alertness with their residents, which was viewed by nearly all the residents once the music began. Dementia is a diagnosis of volatile moods and behaviors. The subjects could have thoroughly enjoyed the music sessions just to have forgotten about them the next day. This phenomenon was also notable in some of the other reviewed research studies in Chapter 2 of this project. For example, one study that focused on exploring the well-being of music concerts and promoting dementia care found a change in resident demeanor and an increase in negative behaviors, even in short periods between songs. While the researcher hoped to show a long-term improvement in mood and depressive symptoms, this may be an unrealistic expectation of patients with this disease process. In conclusion, it is more likely that the observed outcomes would have been similar to the expected outcome if the PHQ-9 was completed directly after a music session. Another inference that can be made based on the study is that the data collection involves the plethora of confounding variables to consider that likely affected resident mood during this month period, such as seasonal changes, COVID-19 restriction changes, and physical health of the residents and their family members. Compacted with a fairly small sample size, this unfortunately leaves significant room for error in the study findings. There are a few strengths of this study. The most apparent strength may have been that the researcher was not only able to compare pre- and post-intervention PHQ-9 scores, but also participate and observe several of the music listening and intervention sessions. This gives the study an informal qualitative component that proved to conjure some notable points. Another strength of the study is that while the sample size was unimpressive, all 38 of the subjects completed the music program. Lastly, all 38 participants of the study had a diagnosis of dementia in their chart, making the study focus solely on the long-term care residents with dementia as intended, and did not include patients with only intermittent forgetfulness or acute delirium. If this study were to be redone or expanded upon, it would be important to include a larger sample size. This may include residents from several different long-term care facilities that are being exposed to the same music listening and discussion program. Confounding variables may be difficult to control, but simply completing the study again, once COVID-19 policies and restrictions have been fixed for some time, would limit the effects of this confounding variable. Additionally, because the mood in this patient population can vary significantly day to day, it may be more beneficial to conduct PHQ-9 questionnaires with each patient weekly and do so shortly after music listening and discussion sessions. Therefore, trends in the PHQ-9 questionnaires could be observed, leaving much less up to chance of how the resident happens to be feeling that day. Although the results of this study were insignificant, this research still has implications for practice and further research. While music listening and discussion sessions may not improve patient mood and decrease symptoms of patient depression in the long term, it continues to be a safe and inexpensive intervention that may have positive impacts on residents, even if the mood and behavioral changes are short term. While unfortunately many long-term care facilities are short-staffed in the time we live in, many of these facilities do have activity departments. Music listening and discussion interventions require no medical background and can be run by these personnel, or even by volunteers within the community. Even interventions as simple as playing the radio during meals may prove to be beneficial in this population. The results of this study found a small decrease in depressive symptoms among this population, along with signs of residents enjoying themselves during the session. Positive effects have been found from several studies on this subject matter, while negative outcomes and risks of music listening and discussion are extremely minimal. Therefore, adding these sessions to long-term care facilities' weekly schedules would prove to have at least some benefit. Additional research on this topic should focus on both qualitative and quantitative findings of music listening and discussion in this population. Also, short-term effects of music listening on depression should be investigated, along with long-term effects. Furthermore, while this research study focused on residents with a diagnosis of dementia, music listening and discussion may prove beneficial to all long-term care residents, regardless of comorbidities. This is an area that we could be investigating in future research. Thank you so much for following along with me and my research project, and these are my references.